The title of the presentation is Therapeutic Updates, Best Practices, and Barriers to Care in the Prevention and Treatment of Osteoporosis. My name is Andrea Traina. I am a doctor of pharmacy, and I am board certified in both pharmacotherapy and ambulatory care. I am currently an assistant professor of pharmacy practice at St. John Fisher College Wegman School of Pharmacy, and my clinical practice site is at the Endocrine Diabetes Care and Resource Center that's affiliated with Rochester General Hospital here in Rochester, New York. I have no conflicts of interest to disclose. Starting with some facts about osteoporosis. 10 million Americans have osteoporosis, and another 34 million Americans have osteopenia. This roughly accounts for 50% of the population over the age of 50 years that have low bone mineral density. 80% of this population is female. 1 in 2 Caucasian women over the age of 50 will experience a fracture, and 1 in 5 men. So osteoporosis is not a disease that only affects women. Male patients absolutely need to be evaluated, their risks need to be looked at, and they need to be treated appropriately if indicated. Of these women that have osteoporosis, only 1/3 of them are appropriately diagnosed, and once they are appropriately diagnosed, only 1 in 7 are treated. Annually, osteoporotic fractures account for nearly 500,000 hospital admissions, 2.5 million medical office visits, and 180,000 nursing home admissions. In 2005, treatment for osteoporosis-related fractures cost $17 billion. One of the things you always want to keep in mind is that age is the most important predictor for a fracture. Women over the age of 80 account for only 8% of the postmenopausal population, but they account for 30% of all osteoporotic fractures and 60% of all hip fractures. The median age of a hip fracture is 83, and this increases at a rate of 1 year every 5 years. That 83 median age is about 4 years old, so we're actually approaching 84 years of age. So there's no such thing as saying patients are too old to have treatment for osteoporosis. Everyone should have their risk factors evaluated, and they should be treated with a safe, effective medication that they do not have any contraindications to minimize their risk of fracture. We'll talk about it a little bit later, but fractures have huge psychological and physiologic complications, and being able to prevent a fracture is much easier than being able to take care of those complications after the fact. In elderly patients, something you always want to consider is that 90% of hip fractures occur following a fall. So not only do you want to think about getting patients treated and prevent their fractures by affecting their bone mineral density, but you also want to focus on non-pharmacologic therapies and minimizing their risk for a fall to prevent a fracture. So vertebral fractures can be symptomatic or asymptomatic. One of the biggest issues with patients who have a vertebral fracture is if they are asymptomatic, patients don't realize that they had a fracture until they have a serial height measurement at their physician's office. At that point, they say, oh, your height's dropped by 1.5 inches or 2 inches, let's get an x-ray, and they realize that patients have had a vertebral fracture. This can be very detrimental. Asymptomatic fractures can have just as many issues as symptomatic fractures because osteoporosis is a very easy disease state to ignore until a fracture. And once a patient has a vertebral fracture, they have a 5-time increased risk for another fracture within a year. Asymptomatic fractures are the same, so whether they know they've had a fracture or not, their chances of another fracture is 5-fold increased. So at least if patients realize they have a fracture, you can treat them and target fracture reduction practices. But in the face of an asymptomatic fracture, it's harder to identify, and patients are at a higher risk for future fractures and don't even realize it. Vertebral fractures also have increased morbidity and mortality associated with them. Non-asymptomatic fractures have associated pain and impaired function. And again, patients will develop kyphosis and have height loss. So it's really important that at every serial primary care visit or specialty office visit, patients have a height documented so that you can look for trends to see if their height has declined from their peak height in middle age. Another important thought is that 3 out of 4 women who've had a vertebral fracture do not receive treatment within that first year following a fracture, thus increasing their risk.